this meeting.
Good evening, everyone. I am Faraz from Clarnet. Clarnet is very proud to be a part of this session as a digital partner. Clarnet, India's largest live CME doctor-generated learning platform. With all, I am presenting you a short video on Clarnet. Thank you so much all doctors for watching the video, and you all are requested to visit our website www.clarnet.com, where you can watch lots of live sessions conducted by expert doctors and across the globe. And we have MedWiki services, which is medical Wikipedia for doctors, and only there you can read. Now, by not taking much time, I would like to hand over this session to Dr. Gunamani Mahanta sir, consultant optician and gynecologist at Guwahati. Sir, please kindly proceed from here.
Hello. 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 Am I audible? Am I audible for us?
Yes, you are audible, doctor.
Yes, yes. A very warm welcome to everyone in this amazing webinar today. I hope it will be very useful and will be enlightened with many practical guidelines in the management of this important topic, the postmenopausal bleeding and management of other postmenopausal symptoms and all. So I first introduce our two eminent guests of honor. First, Dr. Anju Soni, who is the HOD of Gynecology of Department of Soni Hospital, Jaipur, and she is contributing much in the field of women's health, in menopause, and other fields of women's health. And she is a member of International Women's Society, Menopause Society, and she is president of Jaipur Menopause Society. She is committee chairperson, IMS, vice president of Jaipur Option Gynae Society, and many awards are in her name, like COVID Warrior Award, Silver Jubilee Award, IMS, and Appreciation Award by NRC, and many awards. So, and then I welcome Dr. Rashmi Shah as the second guest of honor, and she has numerous contributions in the field of menopause, osteoporosis, and contraception. She organized many workshops and training courses, and she's patron of IMS Mumbai chapter, and she's ex-treasurer and joint secretary of Indian Menopause Society. Then without wasting time, I now introduce our guest speaker, Dr. Subhana Mohandas. Dr. Subhana Mohandas. Yes. He is a consultant gynecologist and laparoscopic surgeon, Sun Medical Center, Thrissur. He is current president of Indian Menopause Society. He is past Secretary General, whose share and website share IMS. He is Senior Vice President, Indian Medical Association, Thrissur. Founder Secretary of Calicut Menopause Society. And she was past active member of FOXI Endocrinology and Food and Drug Committee.
That's okay, doctor. Now, can I speak? Before we start, we have a very great day today here. It is Dr. Anju Soni's birthday. So, Anju Soni, happy birthday to you. Happy birthday to you. Happy birthday to you. I hope you have a great day today. Hope you had a great day. And we'll continue to have a great year ahead.
Thank you, Dr. Shobana. I definitely had a great day with friends, and now I'm going out with my family. So this is my dress. I'm wearing new dress today, just to be pampering myself.
Great. So you give your words of blessings, and then we will shift over to Dr. Rashmi.
Yeah, working with Dr. Shobana, and I think it has been blessing for me to work with her. And her enthusiasm, her love, her guidance has always been there with me. And I am very, very blessed to have a president like Dr. Shobana with me to work along. Thank you, Dr. Shobana, for always being with me. And thank you all IMS members that, since morning I've been reading the blessings and wishes from everyone. And I'm feeling so blessed and so lucky that all of you have made my day feel, make me felt very, very, loved. And I thank you, my whole IMS family, each and everyone. And thank you from bottom of my heart. I will not talk of anything today except this. Thank you,
Thank you,
each and
Anju.
everyone.
Thank you, Anju. Madam Rashmi, you have been a senior member of IMS since the inception of IMS, but she has not left us even today. Anything we want, Dr. Rashmi is there. So we are
Yes.
privileged to have you with us. Please give us your words of encouragement. Please unmute
Dr.
yourself,
Rashmi,
Dr. Rashmi.
Dr. Rashmi,
You're
thank you
muted.
for your blessings. Thank you for your blessings. I
My
saw
pleasure.
them.
My pleasure. Good evening, everybody. I'm very happy to be part of today's presidential webinar on postmenopausal bleeding, which is a very important topic. And I think all of us will gain from today's expert panelists, chairpersons, and to learn from their personal experience as there are case discussions. I'm very happy that during Dr. Shobna's term, you have a lot of academics lined up, having very interesting topics for the presidential webinars like pelvic pain, care of the elderly, anti-diabetic drugs. I think we are always students who have to learn, as what Dr. Anju has always been saying. And there have been a lot of academic activities, a lot of CMEs. But besides the CMEs and academics, I'm very impressed by the visit started for the visit to old age homes and the care for 70 plus women. I'm sure the team who goes to these old age homes will be really blessed. It's a very, very good initiative. The other good initiative is dance and exercise program. I think we take care of other people, we take care of our patients, but we neglect ourselves. And the Sunday morning, for all the youngsters who join in and who do all the exercises, I think it's a very good initiative again. And I think it's doing very well. I am also happy to note that the new membership drive has started, and in such a short span you all have already enrolled 11 new members, and I wish you all the best to see that even this progresses further. Regarding the activities, there are so many, and just yesterday I was going through the IMS newsletter of 129 pages, record broken, and this shows the enthusiasm of the president and her team and all the members from all the societies who are really putting in effort to make IMS a very vibrant society. So with these few words, I would again like to thank Dr. Shobna, Dr. Seema, Dr. Anju and the team for inviting me today. Thank you very much.
Thank you, madam. It's really nice to see two people from Raipur and Seema from Jaipur all have joined in. We feel like that we are a family when everybody joins for all the events.
Yeah.
Over to you, Guwahati. Do you have a chairperson to introduce? Or shall I go?
Ma'am, you start. Now you start.
Dr. Shobana, can I log out?
Okay, you enjoy your birthday.
Thank you. Thank you so much. Thank you, Reshmi and everyone.
Happy birthday, Anju madam.
Happy birthday, Anju ma'am. From
Thank you,
Guwahati,
thank you.
Guwahati.
Thank you. Thank you so much.
Happy birthday.
I'm
Anju
looking
madam.
forward to Jaipur.
Thank you. Thank you so much.
Anju ma'am, wish you happy birthday. Have fun, enjoy.
Thank you. I'm feeling blessed, and this is Dr. Shobna's favorite topic. I've seen it how beautifully she covers each and everything. So enjoy the academics today with her.
Enjoy
Bye-bye.
your evening, Anju ma'am. Happy birthday.
Thank you. Thank you. Bye-bye.
Okay.
Bye-bye.
After that celebration, it's very funny to go to something as dismal as postmenopausal bleeding. Everybody thinks they've thrown out their pads and everything, and hey, God, it comes again. It's not very nice. But then what to do when it comes? You know? So when the patient comes, you are so confused. Is it from the cervix? Is it from the uterus? And they are wondering why pad again, and confusion causes a lot of worry. So that's why we have to worry about it. I'll just tell you, I'll just give you a few clinical snippets so that you don't get bored. One 52-year-old lady was married for only 6 months. She was looking after her brothers, sisters, mother, father, everyone. Then one IVF specialist said, you do a hysteroscopy for her, Shobna. And then I find small tags are there, and then there is simple hypoplasia. For God's sake, I wish I were, she is so surprised. Now what to do? Hyperplasia, how can you stimulate the uterus to put in give ovum donation? Because it's contraindicated, no? So it's whatever is there in books. There are not people to teach you everything on a classical, blackboard, kaisa karo, vaisa karo. Simple hyperplasia is associated with 3% and 8% of rates of progression to complex hyperplasia and simple atypical hyperplasia respectively. So now what to do with this patient? Should she undergo an egg donation program? Should she undergo hysterectomy? Should she undergo? What should we do? So one IVF center said, no ovum donation, because if I stimulate you, it will go into complex hyperplasia. But 1 year later, some other IVF specialist did stimulate the endometrium with estrogen in spite of hypoplasia, and then she got a child. And then now at an old age with a young married couple, they are at 50, they have a 5 or 6 year old child, and she did go into menopause. After that, she has not come back to me with bleeding anyway. So these are things that everything is not there in the books. So we have to learn from our own experience. And this is another patient who had come with postmenopausal bleeding. Ultrasound showed an ovarian cyst of 6 centimeter with internal echoes, no solid area. Endometrium is 5 millimeter, no other lesion in the uterus, no lesions on the cervix, and 2 vaginal deliveries. How to proceed? Will you wait for the ovarian cyst to resolve? Because after all, that must be causing the hormonal problem. Will you wait for it? But she was not willing to wait for it. So when I did a surgery, it was LAVH with BSO, and it was a benign granulosa cell tumor. So you can't always follow, dictum, ki wait karo. And you can miss out on granulosa cell tumors. So you have to keep everything in mind. Ultrasound will sometimes reveal an atrophic endometrium on hysteroscopy, but ultrasound shows the ovarian cancer. So these surprises can also be there. 4.67 centimeter complex papillary cystadenoma carcinoma with a normal endometrium. So with these surprises, let's see what are the commonest causes of postmenopausal bleeding. Atrophy, for God's sake, atrophy is a 60 to 70% of the cases are atrophic endometrium, not granulosa cell tumor, not endometrial hypoplasia, not anything. But you have to think atrophy most of the time. And sometimes they are on exogenous estrogen, polyps. One patient had a polyp and she went on repeatedly doing ultrasound every 6 months. Every 6 months, the polyp is still remaining. Finally, she said, please knock out this polyp for me, because I'm fed up of seeing it. There is vascularity in it also. So these things also cause postmenopausal bleeding. Sometimes they don't cause bleeding, but they do cause bleeding in most people. And endometrial, less than 1% only is cervical cancer, modified from up-to-date Australian family physician. Okay? But postmenopausal bleeding to every woman is cancer, and you get scared. So you have Indian journal, which says the commonest is carcinoma cervix CIN and SCC, unlike the Australians. And then comes atrophic endometrium, where Australians were saying mostly it is atrophic endometrium. Then we have malignant uterus. Then we have proliferative endometrium. Then we have, Then we have inadequate biopsy. So you can't get it by reason at all in those a few patients. So this is how the Indian scenario is, where we have cancer cervix is very common. I'm sure that must be there in Guwahati also. Though in private practice, we don't see much of it. So now, when a patient comes to you, you have to do a PS, although it's very painful in a postmenopausal woman without estrogen. Sometimes they don't even let you touch. So ultrasound is always done. That patients generally allow. And they earn a lot of money because nowadays without ultrasound, you can't do anything. And an endometrial lining thickness more than 4 millimeter is significant in postmenopause. But the endometrium, for God's sake, has to be seen in its entirety to the fundus. And it is not seen in 10% cases. You just see one white line here, there. That is not endometrium. That could be anything else. You can't always diagnose it. These are the pitfalls in an ultrasound diagnosis, you know. Sometimes you can't even visualize endometrium without fibroids. So probable endometrial pathology when the endometrium is isoechoic. Hysteroscopy has to be done if you can't make out on an ultrasound. Non-visualization is there with patients with fibroid. You won't see it behind it. All these cases also, you have to do either a pupil biopsy or a hysteroscopy. So when there is inconclusive evidence on ultrasound, either because of fibroids or because you can't see the endometrium, either you have to do a pupil biopsy, and if the pupil biopsy is inconclusive, you have to do a hysteroscopy. So hysteroscopy is the final answer. And when will you otherwise indicate endometrial biopsy? When there is a thickened endometrial lining greater than 4 millimeter, diffuse or increased echogenicity or heterogeneity, inability to visualize the endometrium. This is just repetition. But beware. This use of 4 millimeter endometrial thickness as threshold may miss endometrial cancer for 1 in 339 patients. I don't know how many patients you all have in an OPD, but you have to see that many patients to miss it. But maybe in a few years, every gynecologist will miss one endometrial cancer. If you just think of endometrial thickness as one thing. Therefore, that's why none of us take a risk. And when they come with postmenopausal bleeding, endometrium or no endometrium, do a pupil biopsy or a hysteroscopy. That is the dictum. Now, there is a problem with inadequate biopsy. That's not because the gynecologist is not as experienced and the PG is doing it, or gynecologist is not good enough. It's not like that. It is a known entity. It's reported in RCOG. It's reported in Australia. It's reported in FOXI guidelines. And most of them are saying that inadequate biopsy, you have to do a hysteroscopy. So it's a known thing. You tell the patient, this is there mentioned in books. It's not because I have done the thing wrongly. It is a known thing. And there you have to do a hysteroscopy, because you can't get a thing. Now, fluid in the endometrial cavity will be a problem. There you minus the fluid and then you take out the thickness. These are the pitfalls. And then suppose you see a polyp, how do you know whether it is significant or not? If there is a central vessel in the polyp, then it is predictive of endometrial cancer. But quite often I have found that when you do a central vessel and then when you do a hysteroscopy, I just find the usual polyp-like appearance. It's not a cancer. It's not that all this color Doppler identifying feeder vessels is always endometrial cancer. In my practice, this is not always the same, but whenever you see a high vascularity on color Doppler, you have to do a hysteroscopy. And if you don't have a hysteroscopy, you have to do a thorough curettage. I tell my patients they may miss it otherwise. Now, one thing is there, endometrial polyps can occur with an obesity. It's not just some, other things like cancer and all. Even polyps can be there because peripheral conversion of androgens by adipose tissue to by tissue aromatase activity will raise the circulating estrogen levels, and that can increase the polypoid activity of the endometrium even in the post-menopause, where she was not having any bleeding earlier. So now, then suppose inadequate biopsy is there. I told you Australians, Indians, and RCOG have talked about it. Then they will go doctor shopping. This doctor doesn't know how to do endometrial biopsy. Suppose that person comes to you. Will you do another ultrasound? What will you do? Will you ask for another endometrial biopsy? Will you ask for a hysteroscopy? What will you do? Will you do to convince the patient, if you think you can do an ultrasound, will you do ultrasound immediately? They are not going to listen to you if you say you have to do a hysteroscopy because FOGSI guidelines in that. They will say, pehla scan karke dekho. But beware, in a patient like this, the endometrial biopsy has already been taken. Ultrasound should be delayed by 2 weeks because the inflammatory reaction of the biopsy can give a wrong report. So you have to go, pacify her with some other words, give some placebo treatment for 2 weeks and then call her back if she is not convinced for hysteroscopy immediately. That is there. Now, what about endometrial biopsy? Endometrial biopsy more than 4 millimeter, fibroids, you can't see it. Persistent postmenopause. This is just repeat. So all these cases you have to, even endometrial thickness is more than 3 millimeter with fluid, then you have to do a biopsy. So now, if this is just repeat of American college, they also say that you have to do a hysteroscopy. I told you about Australians, Indians, and RCOG. And if in such a patient, if you get a biopsy report where you can't find anything, see the right side report. There you have to do a hysteroscopy. Now, what are the types of biopsy that you can get? It can be scanty, it can be fleshy, it can be moderate. So, in most of the cases, in spite of a thick endometrium on ultrasound, in this study, they found out in obstetric gynecology, it's done by an Indian, Kottapulli K et al, whatever, but it's come out in an international journal. But let me tell you, even when there was thick endometrium in that study, 47% showed a scanty endometrium when they did an endometrial biopsy. You understand that? So in your practice, when you find a scanty endometrium, don't get scared. Even other people who have conducted studies are seeing the same thing. So that's something. Now, how do you manage the patient? With benign endometrial hyperplasia, you may wait. Endometrial hyperplasia with neoplasia, of course, you have to do a hysterectomy. Ablation, morcellation should never be performed. Medical management is an option for patients desiring surgery or who are not desiring surgery or who desire fertility. There you can give drugs like megestrol acetate, micronized progesterone, levonorgestrel IUCD, but for God's sake, tell the patients that yes, there is a percentage of women with endometrial cancer in situ who will go into endometrial malignancy. So having understood that, if she still wants to continue with medical treatment, she may go on with that in endometrial hyperplasia. Atypical hyperplasia hysterectomy is the treatment of choice because there is a risk for progressing. In bilateral salpingo-oophorectomy should be considered even in premenopausal women as it may reduce the risk of future ovarian malignancy. No benefit of frozen section or lymphadenectomy. Some studies will say remove the lymph node, send the patient to oncologist. Some such studies don't say lymphadenectomy. So we still have not reached a conclusion on that, I think. Now I'll give you for another interesting case of a 70-year-old postmenopausal lady who comes with an endometrial biopsy report of hyperplasia of endometrium, few atypical cells. So what do you do in this patient? Why hyperplasia in a 70-year-old woman? When atypical cells are seen in the endometrium, the dictum is that oophorectomy should be done at the time of hysterectomy in the postmenopausal woman. And so by dictum, I did the LAVH PSO and the ovary did look atrophic, but the histopathology showed adenofibroma in one of the ovaries. That's why there was endometrial hyperplasia. So these are the surprises that you see in women with postmenopausal bleeding. So can thermal ablation be done in a woman with hyperplasia? No, because if you have synechia in between the uterine walls, then if cancer develops beyond the synechia, even if you do a biopsy, you can't do a hysteroscopy because the synechia will prevent you from doing it and your pupil won't reach beyond that synechia. Therefore, definitely in patients with hyperplasia, you are not supposed to do a thermal ablation. Now, irregular bleeding episodes with atrophic endometrium and no other pathology. I told you, as Australians had a very high incidence of this, Indians don't have that high incidence. But what will you do? You have to give your antifibrinolytics, but you can give low dose of estrogen and progesterone combined. But of course, not in patients with metabolic syndrome, you will get GVP. That is there. So moderate bleeding, patient is bleeding, but what you see, I told you thick endometrium, but no biopsy. That is an atrophic endometrium. What will you do? You have to give Premarin or, conjugated estrogen in doses of 1.25 to 2.5 milligram, followed by progesterone. So there, even if it is a DVT, risk is not there. And what will this do? It will cause vasospasm of the uterine arteries. It will initiate the coagulation related functions and rapid proliferation of the endometrium. So when the endometrium proliferates nicely, it will slough off all together in one go. So it will not bleed continuously. So in these patients, you have to give estrogen, not progesterone. So what is the history? Again, indication for hysteroscopic can also be unable to pass the pipple sample, suspected polyp, endometrial thickness more than 11 millimeter. I don't know it's really indicated or not. I told you sometimes you won't get any this thing. Inadequate visualization of endometrium on ultrasound and recurrent postmenopausal bleeding defined as 2 attendances to the clinic with two biopsies, pipple biopsies more than 6 months apart in the last 2 years. So in these cases, you have to do a hysteroscopy. Now, will you insert a levonorgestrel IUD for additional effect after TCRA? It's very tempting, no? You think that some endometrium has not been removed, and why don't I put in a IUD also? But no, you can't. You know what happens after TCRE? The insulin after the synec will stick it together, and you won't be able to remove your IUD out. Suppose she has got some problem. Sometimes these IUDs just turn around and things like that. And then patient comes and says, remove it, remove it, remove it. Then you won't be able to remove it. It will be all stuck between synec. So, however tempting it is, for God's sake, do not put a IUD inside after a thermal TCRE or a thermal ablation. It can be really scary. Now, to summarize, USG should be done to rule out uterine or ovarian pathology in PMB. Inadequate pipple biopsy is a common problem. Don't feel guilty. GNC and hysteroscopic biopsy may be needed. You can't say DNC is out because a lot of people don't have a hysteroscope. Oophorectomy should be done if the endometrium shows atypical cells. And thank you. And welcome to Calicut for IMSCON 2023 in February 16, 17, and 18. So we have a lot of academics and everything live for you. And there is a hill station. I know Guwahati is already a hill station, but and see, if you want to see another hill station, you can come to Calicut. Edekal Caves and other things are there nearby. Thank you so much.
Thank you. Hello.
Yes, sir. We can hear you. Thank you, sir.
Thank you, ma'am, Pavana ma'am, for your excellent presentation. You have covered everything in a very short time, and you have in a very comprehensive way. You have you have tasked everything and all recent management. So thank you very much. Thank you very much.
Does anybody have anything to say on this, or we'll go on to the panel now? Anyway, they are coming with the panel with a lot of interesting cases as it is. So we are excited to hear how the Guwahati people manage postmenopausal bleeding in their clinics.
Thank you.
Over to you.
Over to Faraz.
Hello, sir. Kindly proceed.
Faraz,
Yes,
you can
sir.
proceed for the panel discussion.
Yes, sir.
Yes.
Are you going to present that PPT?
No.
Okay, sir. So, who is going to next come?
Dr. Dilip Sharma.
No.
Dilip Sharma and Manjuma Baidu.
Haraj Dr. Manjima Ganguly is the first one.
Okay, sir.
Manjima, can you please, who will introduce Manjima? Do you have Manjima's CV?
Paras,
Can you
Gunamuni.
please introduce
Paras.
Manjima, sir? Guramoni
Gunamuni.
Mahan.
To me,
Please introduce Manjima and Dr. Sharma, please. From whatever you know of them.
Yuda.
Gunamuni Kwa, please.
Please introduce Dr. Manjima and Dr. Sharma.
Yes, I welcome to a very important panel discussion on postmenopausal bleeding and other postmenopausal problems. Now I welcome to Dr. Dilip Sharma, with a senior consultant of obstetrics and gynecologist in the Menopause Hospital, Guwahati. And also I welcome Dr. Manjima Ganguly, he is a senior consultant of the ESIS Guwahati. So please proceed for the panel discussion.
Please introduce your panelists, Dr. Manjima and Dr. Sharma.
Dr. Sharma.
I welcome all the panelists.
Please
on
introduce them to us. We do not know who they are.
Introduce the panel.
Dr. Meenakshi Sharma. She is the consultant gynecologist in Guwahati in a private nursing home. Then Dr. Onit Dhruti Datta. She is also a practicing gynecologist in Guwahati. And Dr. Hemango Vishwa, practicing gynecologist, all are private practitioners. Then Dr. Mamta Sharma, it's a very intelligent gynecologist receiving award of Indian Menopause Society award for this examination in Kolkata annual conference.
exam.
CIMP exam. And next, Dr. Asa Agarola from Guwahati, a private practitioner, consultant gynecologist. She is also received the CIMP award in Kolkata examination. So and
we have Dr. Rashmi Banerjee from
and Dr.
Baroda.
Rashmi Banerjee, ma'am from Baroda, and our moderator is Dr. Manjima Ganguly, along with me. She is the senior gynecologist working in ESIC Hospital, Beltola, and is a very active member of Guwahati Menopause Society, performing many social activities as a member of Guwahati Menopause Society. So first I welcome
Sir,
Dr.
can I please introduce Dr. Rashmi? I please.
Ma'am, yes, ma'am. I will be thankful to you. I will be thankful.
No, ma'am. I'll introduce myself. My name is Dr. Rashmi Banerjee. I'm basically Bengali, but born and brought up in Gujarat. So I have an Eastern connection, and I'm the president of the Vadodara Menopause Society. And I'm glad for this invite, and I jumped at the invitation immediately when I received it.
So you don't want me to read your CV, Rashmi?
No, ma'am. It's okay. We'll move on to the academics. It will be more.
Okay, you please don't talk in Bengali now, because you are here in Assam.
No, surely no, ma'am.
Okay. Over to you, Manjima and Dr. Sharma.
Good evening, everyone. It is indeed a delight for me to be here amongst you all. And our panelists must be very thankful to Dr. Shobna's Mohandas's talk, because it has made the things more simple, because she has elaborated in such a lucid manner. So we have already benefited. So can I now share my screen?
Yes.
Is it okay?
Yes.
Actually, I think I will have to go back, because
you have to go to case one.
I'll have to go to case one. So
no, you don't have to stop sharing. You could have just gone back on the screen.
Just a second.
Reshare. You have stopped sharing. You have to start resharing and go to slide one.
Thank you very much.
Yes. This will be.
Make it slideshow. Then it won't go again.
From the beginning, I think this will be okay.
Yes.
Oh, it is again coming as case 4. That is the problem.
Then you just describe your cases, since your panelists may be knowing. They are giving their own cases. You just ask them. They will giving their cases, I think. No.
Can I share this way? Because
yeah, okay, this way it's okay.
From the current slide, most probably it will come.
Ma'am, this is ma'am,
Yes.
ma'am, this is the first case.
Yeah. So if I give from the current slide, I think it will come.
Yeah. I don't know. You just start reading
no.
out from this. No, again it's going.
Why don't you give it in?
Hello, ma'am. Sorry to interrupt you, ma'am. Kindly go with.
No, you just don't go to slideshow at all.
I will have to go in this manner. I suppose.
Yeah.
So, postmenopausal bleeding is the bleeding
I'm
which
sorry
occurs
to
after
interrupt you,
menopause,
ma'am. Sorry
and
for
it is a
interruption.
stage in a woman's life where the
Hello, ma'am.
reproductive.
Sorry for interruption, ma'am. Kindly put this slide on full screen from the beginning. The slide 1 only will come, ma'am. Go to the from.
But she's not able to manage. She's not able
it
to
is
do
coming from the beginning.
She's not able to manage
Number
it.
4 is coming. That is the
Okay,
problem.
she's not able to do it.
Ma'am, try one. Please try
She's
one
tried
time.
it 3 times. It's not coming. You carry on.
Okay, ma'am. You can proceed then. Okay, thank you, ma'am. Thank you.
So it is a stage in a woman's life where the reproductive hormones stop and a monthly menstrual period stops. This occurs more than a year after the woman's last period. So the next slide. Here we have the case 1. She is Mrs. X, age is 54, weight is 62 kg, para 3 with 1 abortion. She attained menopause 5 years back, and she complains of bleeding PV for 2 days with spotting only for 2 days, and she has been diagnosed with as hypothyroid, and she's on levothyroxine 50 micrograms. She is also on antihypertensive medication, and her sugar level is normal, and there is history of breast cancer in the family. There is no previous history of surgery, and all the deliveries are normal.
Who is the question to, Dr. Manjima? Please tell the name of the panelist.
Just a minute, please. There's something.
Can you please tell us who you are addressing this question to?
Yeah. I have not yet started the questions. So a little bit about her history. Her blood pressure is 130 by 80. Her pulse was 82, pallor negative. Breasts were normal. First speculum examination, the cervix also looked normal. Uterus bulky. Fornixes were free. Hemoglobin was 11.7. RBC 88 milligrams per deciliter. TSH was 6.5. Prolactin 11.2 nanograms per ml. Lipid profile is normal, and urine RE is normal. Vitamin D is 19.56 nanograms per ml. ESR is 11 millimeter. On TVS examination, it is seen that the endometrial thickness is 3 millimeters. There is no endometrial polyp. Multiple myomas are there. Positions being intramural, one in the right lateral body of the uterus with a size of 28 into 27 and another of 17 into 10 at the junction of the cervix and corpus. And the cervix is also normal. Cul-de-sac is free. Ovaries are atrophic. No abnormal adnexal mass seen. And pap smear is normal without any intraepithelial neoplasia with more basal and intermediate cells. And this has been remarked as a atrophic smear. So coming to the questioning, first of all, I will ask, what is the most common cause of postmenopausal bleeding? And I put this question to Dr. Triti. Dr. Triti,
good evening, ma'am. Yeah, good evening, ma'am. Am I audible? Can you hear me?
Yes, you are.
Yes.
Yeah. These are just the repetitions of what ma'am just said. You all know atrophic endometritis and cervicitis is almost 60 to 80%. Besides that, we have exogenous estrogen administration, as madam has replied. And then we have endometrial and cervical polyp in almost 2 to 12% cases. And we have endometrial hyperplasias in 5 to 10%, and endometrial cancers, carcinomas in almost 10% cases. And besides that, we have certain rare causes like post-radiation or some patients on anticoagulants, and there could be infection, endometritis. So these are usually rare causes, but atrophic endometritis, as the stage looks, is one of the very common causes of postmenopausal bleeding.
Okay. So there are some less common causes. I'd put this question to Dr. Asha Agarwal. What are the less common causes of postmenopausal bleeding? Dr. Asha, please.
Yes, thank you, Manjuma Baidu. There are miscellaneous causes which comprise around 10% of all the incidences among this postmenopausal bleeding. As already Dhiti has elaborated about this, is the cervical cancer, the cervicitis and endometritis also, and bleeding from other areas like nearby structures like bladder, rectum, and from the skin of the vulva. Also, sometimes we see some caruncle and all those. And we need to see if the patient is taking any anticoagulants or any other drugs that interferes with the bleeding, which results in increasing in the endometrium, the size which is measured in the ultrasound.
Thank you, Dr. Asha. Now, how would you evaluate such cases? Dr. Mamta, could you give us a brief?
Yeah, good evening. Good evening. Thank you, ma'am. Postmenopausal bleeding can sometimes lead to a serious diagnosis, so we have to evaluate these cases very carefully. First, a good history taking is, I think, very important. We should start from the family history. If the patient has any history relative with gynecological cancers, including colorectal cancer also, I will mention, because the age group is almost same. And if there is any history of drug use, such as anticoagulants and antidepressants, because antidepressants sometimes also causes failure repeated aggregation, such as serotonin inhibitors. And ginseng, which is used in some of the medicines, if they are using chronically, that has to be also asked. And there are also it is must be remembered that good clinical examination is very important, because the bleeding may come from the endocavity, not only from the endocavity, but the cervix, vulva, vagina, also the nearby structures such as rectum, urinary bladder, because we also should take the history of whether the person has any history of hemorrhoids, bladder polyp, which has been excised before, that may also recur. And we also can see some erectile caruncle, which is very easy to identify. And the investigations, I won't go much, because we all do the necessary investigations elaborately. But the gold standards are the pap smears, is all done in all cases. Plus, the gold standard for only gynecologist is TVS, which will so give us some idea of how to proceed. So, who are the cases? Madam has already elaborated who are the cases that has to be put on his endometrial biopsy. But from my take, what have I managed, how I managed, that I want to say. If I say that the endometrium is more than 4 millimeter and it is ecogenic and there is fluid and irregularity, then straight away we should go for hysteroscopy guided biopsy. And if the endometrium is less than 4 millimeter, I would divide the cases into low risk and high risk group. The high risk groups would be the patients with comorbidities like obesity, diabetes, hypertension, patient who had already taken exogenous hormone therapy for any cause, and patients who are more than 65 years of age. These patients must go for endometrial biopsy, even if the endometrium is not that thick. And the low risk patients who has endometrial thickness less than 4 millimeter, they can be put on expectant management, but the surveillance must be done serially, so that if there is any pathology suspected, they should also be put on hysteroscopy guided biopsy.
Thank you, Dr. Mamta. That was indeed a very elaborate way of evaluating the case. So I want to ask Dr. Asha the next two questions, which are almost been covered. So before diagnosing atrophic endometritis, Dr. Asha, what are the pathologies that should be excluded? And can this atrophic smear be misinterpreted as neoplasia? Dr. Asha? Dr. Asha Agarwal? Asha, can you hear me?
Hear you. Yes, ma'am. I can hear you. Before diagnosing atrophic endometritis, there are other pathologies excluded, which we have already elaborated the causes of postmenopausal bleeding. All those which include in this answer, I believe. And smears can always be misinterpreted as neoplasia because it is always histological diagnosis. What we see here is there will be no chromatin clumping in the under the microscope, which is not seen, and there is no nucleoli seen, and also there will be sharp and regular nuclear membrane which is seen under the microscope, and there will be the absence of mitotic figures, which are the actual hallmarks of the atrophic smears.
Thank you, Dr. Asha. Now I will ask the next question to our guest panelist, Dr. Rashmi. Will you recommend hormonal therapy to this patient? And if so, how will you follow up this case? Dr. Rashmi,
Yes,
please.
yeah, definitely. So for atrophic endometritis, once the diagnosis is established that it is atrophic endometritis, hormonal therapy will be the mainstay. So we'll give them sequential estrogen progesterone therapy for regularization. And initially we'll call them after 1 month for follow-up and then after 3 months. But definitely the pre-evaluation has to be complete. Especially we should also do a mammography, at least a baseline mammography should be done before starting with hormone therapy for them.
So this more or less, this more or less summarizes the atrophic endometrium. So one of the most common causes of bleeding is the is endometrium. Atrophy endometrium, and TVS remains the gold standard for diagnosis. The endometrial thickness is important for biopsy indications. So mostly reassurance is very important to these patients. Local vaginal estrogen can be recommended, and short courses of OCP can also be given. When you have tamoxifen use, it needs the follow-up in the form of DNC 6 monthly.
Here,
So
I think rather than OC pills, we should go in for hormone therapy, because the OC pills will contain a progesterone which is not safe in the postmenopausal period. So post-WHIT is now well established, because either dydrogesterone or natural micronized progesterone is a safe progesterone for postmenopausal patients. So
no, I just want to ask Shobna ma'am one thing. If a patient comes with atrophic endometritis and she's giving a history of spotting, do we and after the investigation we see that it is just an atrophic condition, do we start away give away her OC pills or give her assurance? And if the bleeding is persistent, only then we call her after 2 weeks or 3 weeks and then start the OC. So I think, do we, I mean, madam, do you just start away with OC as soon as you diagnose that she's atrophic, or do you wait and watch and again you call her back because you know that these things can subside on their own? I just like either Banerjee ma'am or Shobna ma'am to answer that.
I think recurrent postmenopausal bleeding would require sequential pills, like we said, but we'll wait
but
for
it has to be persistent.
Yeah, sure.
Yeah, it has to be persistent. That is what comes straight. Okay, ma'am. Thank you.
So let us go to the next next case, because we have quite a few cases lined up. So next patient, we can call her M. Her age is 53 years. She's obese, weight is 90 kgs, para 2. She has had all normal deliveries. She is hypertensive and she is on telmisartan and amlodipine. Hypertension is not yet much controlled. She has been postmenopausal for the last 2 years. She is hypothyroid. She takes levothyroxine 100 micrograms. She has complained of heavy bleeding for the last 7 days. BP is 160 by 110. Pallor is there. Uterus is bulky. On speculum examination, bleeding is present. Cervix looks healthy. And on TVS, the uterus is bulky with endometrial thickness of 11 millimeter with cystic hyperplasia. Adnexes are free, ovaries are atrophic. We did an endometrial biopsy was done, and histopathology shows cystic hyperplasia without atypia. In this patient, she underwent hysterectomy with bilateral salpingo-oophorectomy. So Dr. Shobna has covered this in detail, but even then I would like to ask my panelists. So Dr. Hemanga, the first question I'd like to ask you, what are the risk factors associated with endometrial hyperplasia? Dr. Hemanga?
Yeah. Good evening, everybody. As we all know that endometrial hyperplasia is caused by excess of estrogen without progesterone. So the risk factors are generally the progressive age, nulliparity, early menarche, late menopause, another factor, and history of certain conditions like diabetes, PCODs, which is very common nowadays, hypertension, thyroid disease, gallbladder disease. These are the commonest cause. Then cigarette smoking is another risk factor. Family history of ovarian cancer, colon cancer, and uterine cancer. And also tumors that are producing estrogens. These are also causes. And last but not the least, drug-induced. Exogenous estrogen is another cause of a risk factor for endometrial hyperplasia.
Thank you, Dr. Hemanga. Now, Dr. Meenakshi, what are the complications of endometrial hyperplasia? Could you tell us in brief? Dr. Meenakshi, please.
Yeah, I'm here. Good evening, everyone, and thank you, ma'am. The complications, endometrial hyperplasia, the main complication is that it may lead to endometrial CA. So that is what we're afraid of, and that is what we should look after and treat. So either it may be simple hyperplasia or it may be a typical or according to this new guidelines, that is, it may be an endometrial hyperplasia with atypia or without atypia. So with atypia, I think maximum it progresses to cancer. So we have to be aware of that. And
8 to 29% progresses, and without less than 5%. Okay, thank you, Dr. Meenakshi. Now, Dr. Dhriti, how is endometrial hyperplasia managed or treated? Dr. Dhriti, please. Dhriti.
Yeah, can you hear me? Yeah. As Dr. Meenakshi said, endometrial hyperplasia, we can divide it into atypia and patients with atypia and without atypia. With atypia, directly by the we would go for hysterectomy with bilateral salpingo-oophorectomy, as was mentioned by ma'am. And without atypia, first and foremost, we can assure her that it's less than 5% even in 20 years. And so she could just be reassured that it's going to subside on its own. Now, if this woman on follow-up, she has complaints of bleeding, in those cases, we can put her on progesterone therapy. And the best is LNG-IUS, which is locally acting and which helps in maximum regression of the endometrial lining. And if somebody is not happy with LNG-IUS, like Mirina, we could put her on medroxyprogesterone acetate. We could put her on a medroxyprogesterone acetate for 3 months. And then we, kind of keep checking her every 6 months to see whether there is regression of the hyperplasia.
Okay, this would be a continuous therapy, I guess so, right?
This is a continuous therapy. Yeah,
Thank
we don't
you.
want a cyclical therapy in such case. Yeah.
So, Dr. Mamta again. So already, I think Jyoti has said, but I would just like to emphasize: how long do you take progesterone for endometrial hyperplasia? Dr. Mamta.
Yes, endometrial hyperplasia without atypia. We can put the patient in IUS or orally acting norepinephrine or medroxyprogesterone for 6 months, and we can reevaluate the patient for any histological regression of hyperplasia.
Thank you, Dr. Mamta. So to summarize, endometrial hyperplasia, as the new guidelines have said, you have said it is maybe without atypia or with atypia. So most of the 8 to 29% of the cases, they progress to endometrial cancer. if left untreated, and less than 5% of the cases without atypia may progress to cancer. So in cases with atypia in most postmenopausal women, hysterectomy followed by bilateral oophorectomy is the preferred treatment. And without atypia, we can give progestogens, oral or injection, and also LNG IUD is the preferred treatment. So I think case 4 will be taken up. Case 3 is there now again. Sorry, case 3. So case 3 is Mrs. N. Her age is 54 years. She's a working woman. Her weight is 60 kg, para 2. She has had both vaginal deliveries and she's non-diabetic and non-hypertensive. She has been complaining of spotting for 2 days and she has been postmenopausal for the last 4 years. Her BP is 130/80, pallor is negative. On per vaginal examination, uterus is normal size. Specular examination shows spotting is positive, though the cervix looks healthy. TVS shows a normal endometrium with minimal collection in the endocavity. Adnexa also normal. And pap smear hysteroscopic guided was normal. And when you did a hysteroscopic guided biopsy, it was done and minimal blood was seen in the endometrial cavity. And the report showed proliferative endometrium. The treatment planned was TLH. On operation, a small firm mass of less than 1 centimeter was found in the left fallopian tube. And the histopathology said that it was a well-differentiated adenocarcinoma. The patient was then referred to the oncologist and she had taken 3 courses of chemotherapy till now. And second look surgery also was done and she's doing well at the moment. And this is her 3rd year of surgery. So I would like to ask just a few questions. Dr. Hemango, what are the types of endometrial carcinoma? Dr. Hemango, can you hear me? Dr. Hemango?
Yeah.
Yeah. What are the types of endometrial carcinoma?
Yeah, squamous cell and adenocarcinoma, these are mainly present.
Asha, could you elaborate it a little bit more, please?
Yes, Manjuma Baidu, I can. There are basically 2 types, type 1 and type 2. Type 1 endometrioid carcinoma. This type of uterine cancer forms in glandular cells of the lining. It accounts for more than 75% of all uterine cancers. Endometrioid adenocarcinoma is the commonly detected very early and so it has got a very high cure rate. And type 2 is non-endometrioid endometrial carcinoma like papillary and clear cell carcinoma and squamous cell carcinoma. They are very lethal and they are diagnosed very late. So the survival rate in this type of carcinomas is around 5 years, even after doing operation.
So what is the percentage of endometrial biopsies that are cancerous? You can continue this, Asha.
Yeah, patients with endometrial specimens that show atypia have about 25% likelihood of progressing to carcinomas and compared with less than 2% those who don't have atypia.
Thank you, Dr. Asha. So here I wanted to even say that sometimes we have these polyps and during ultrasonography and all, we have to distinguish it from this cancer. So Dr. Mamata, how would you manage a polyp in postmenopausal woman?
A postmenopausal woman with an asymptomatic polyp without any symptoms, she can be counseled that there is no need of surgery immediately, but she should be evaluated after at least 3 months or 6 months because some polyps are the seat of endometrial carcinoma, especially the squamous cell carcinomas and papillary carcinomas, because in a non-hyperplastic endometrium. So that is the region we should not leave it, we should not ignore it completely, and we should evaluate the patient in certain intervals because it may develop into carcinoma or Otherwise, there is no need of immediate surgery.
Dr. Meenakshi, how would you differentiate between a polyp and a submucous myoma? Dr. Meenakshi.
Yeah, I'm here. Basically, it's a radiological diagnosis. A polyp will usually have a stalk with a vascular pedicle, whereas the submucous myoma will not have. Plus, the capsule will be very visible in the radiology with a different texture. It will be a solid texture in submucous myoma, whereas in the polyp, it will not be so. And the vascularity will be different in both.
Does color Doppler help in distinguishing this? Color Doppler?
Yeah. Color Doppler will. Yeah, because your pedicle will be visible in the Doppler.
Yeah, right.
So in
right.
that case,
See the
you know it's
pedicles,
a polyp.
Dr. Isan.
And pedicle will be seen in polyp, and if not, it's a submucous myoma. And finally, by hysteroscopically, when you remove, then you know.
Okay. To summarize the endometrial carcinoma, we have got now two types, type 1 and type 2. And 75% type 1, type 2, 25%. Prognosis is better in the former due to the early diagnosis. Polyps also may be present. So in postmenopausal bleeding with polyp, 2.3% may be malignant. Otherwise, most polyps are benign. Around 2 to 12% of all cases of postmenopausal bleeding are caused by polyps. And color Doppler can be used to distinguish this polyp from the submucous fibroid. Certain investigations are there, though maybe we don't do it very commonly, like saline contrast hysterosonography or gel installation sonography. These are some of the other procedures. And hysteroscopy with guided biopsy, this can be a curative method also. But decisions to remove the polyp must be weighed against the risk of the maneuver because versus the risk of malignancy. And as you all know, risk of malignancy is less in endometrial polyp. So this case 4, I think we can, Dr. Dilip will take over from case 4 onwards. Dr. Dilip. I would like actually Dr. Dilip to take over the next 2 cases since he is also a co-moderator.
Okay, ma'am.
Yeah.
Ma'am, you shall stop your screen sharing so that I can.
Okay. All right. Yeah.
Thank you, everybody. I am very much happy that our panelists are so intelligent and they have answered so many things so clearly. Somna ma'am, are you want to add anything in these 3 cases before discussing last 2 cases?
I just want to know if you have a hyperplasia and you put LNG IUD, you are supposed to do the endometrial biopsy every 6 months, no? So will you do it with the LNG IUD in situ? And does anybody have any experience of putting 2 IUDs inside? You know, when I went abroad, not abroad, in the one of the webinars, this foreigner, he was saying, I put 2 IUDs inside. So sometimes I had a patient with endometrial polyp, I removed, and today she came back after 5 years. I say, doctor, even after the polyp was removed, I am getting heavy bleeding. And then if she had come to me earlier than this, I would have put in a LNG IUD. But sometimes even LNG IUD, after that also they get so much of bleeding. So should we try to put 2 IUDs inside? And plus, if there is only 1 IUD inside, should you take a biopsy after 6 months? So all these things, if
whether we go for a biopsy or we do a transvaginal scan to see whether the endometrial thickness has become less. I mean,
but then should you not do a biopsy?
If
there are people who say in situ, if you put the IUD also, you do a biopsy. Make sure it's not going into cancer. Because, so that is one point that we want to raise. So I just want to say that this putting 2 IUDs is being done by some people abroad. Of course, none of us are started doing it, but एक idea hai, bas, that's all.
But so, madam, post-menopause, we might as well ask them to go for a hysterectomy.
I know, post-menopausal
doesn't make sense, man. Yeah,
youngsters, you can do that. This is post-menopausal.
Menopausal, it doesn't make sense.
It's so scary. You will have some fibroma, you will have some granulosal tumor. The scan maybe nahi dikhte. Okay,
Thank
that's all that I can talk from my side. Anybody else? We will finish the panel and then we'll have a discussion if at all.
Okay, ma'am. Okay. So this is the case for this class also dealt with by me by myself. She was
Hello, sir. Again, sorry for the interruption, sir.
52 years lady.
Hello, sir.
Aspires, what is the problem?
Yeah, sir. Sorry for interruption. Sir, if you possible, please put this slide on full screen, sir. So it will be good. Again, there is the option of slideshow. Click on it.
Doesn't matter if they're not able to do it, leave it.
Yeah.
Maybe they're not used to doing these things. So don't insist.
Okay, no issue. Then
No, we
continue.
are used to it, but somehow it was not coming. So instead of wasting time, I thought I might as well show it in this manner.
दिलीप दा अपनी स्लाइड से ले जाओ जैसन दिलीप दा जाओ
Dilip can try. Maybe it
There
might
is
be
an option of slide social. You can see above.
Excuse me, Dilip, I have to join
Okay,
another.
don't insist on this, Fires. Let's have a pure, good flow of the talk
Yeah,
and not
that would
worry
be
about
better.
technicalities.
Thank
Because
you.
it would waste some time.
Just I am trying. Whether it works or not, I don't know. It's okay now.
No.
No, it's okay now. It doesn't matter. You just continue with discussion. It hardly matters if nobody can read it because we are reading it out anyway.
Okay. So Cassandra is a 52 years old lady. She parity 3 plus there is no abortion. Menopause attained 7 years back. All were vaginal deliveries. But surprisingly, at the time of third pregnancy, she was diagnosed to be having a subserous fibroid of around 3 centimeter in size. She is non-diabetic, non-hypertensive, with normal lipid profile and normal thyroid status. She complains of occasional spotting for 3 months with pain in abdomen. Then I have done clinical examination, which found that her BP was normal, mild pallor was there. On abdominal examination, I find just palpable mass in the suprapubic area. It was tender on deep palpation. Then PV, I did PV. I found uterus to be bulky with restricted mobility, but both fornices on right and lateral fornices were free. Speculum examination, there is occasional spotting. Cervix looks healthy. Then normal blood investigation, hemoglobin was 9.5. Others blood parameters was normal. Markers I have done markers, but it very negative. Then transvaginal examination was done by one of my colleague. He told that uterus is bulky with a solitary, well circumscribed, big mass in the myometrium around 7 centimeter in size, with hyperechoic center. That radiologist thought that it could be necrosis, but the mass is not impinging on the endometrium. It was away from the endometrium. Calcification was noted at places in the capsule of the myoma, and loss of demarcation seen between the mass and the myometrium. Both adnexy was normal. I have thought of doing MRI also, but patient was from the low socioeconomic background, so I could not done MRI. So ultimately, I planned total abdominal hysterectomy with bilateral histopathology shows that it was a case of leiomyosarcoma. Her postoperative period was otherwise uneventful. After 3 weeks of post-operative period, I have referred her to a oncologist. And after that, patient was not traceable to me, whether they have attended the oncologist or not. So this is the case. So now I want to have some questions. So first question to Dr. What is a degeneration of myoma? When you say a myoma to be degenerated,
good
both
evening, Dilipda.
clinically and radiologically.
Yeah, good evening.
Good evening.
When the fibroid stop receiving the blood supply, or when the fibroid outgrows its limited blood supply, in these conditions, the blood vessel cannot provide enough oxygen to the fibroid.
Yes.
And so the cells begins to die. And there is degeneration.
Okay.
So this is the common cause.
What are the types of degeneration? That is one, maybe hyaline degeneration, maybe red degeneration.
Cystic
Commonness
degeneration
is
is
the
there. In pregnancy, there is red degeneration. It's common, but generally hyaline degeneration is very common, and cystic degeneration is also there.
Okay. Okay. Thank you. Thank you. Thank you very much.
Excuse me, Dilip. I have another meeting of the IMA. So
Okay.
I have to
Okay. You are free. Somala ma'am, Hemango will be joining another webinar.
Okay. Thank you very much.
Then okay. Then next question is to Meenakshi. Meenakshi,
Yeah, I'm here.
do degenerating fibroids needs to be removed? What do you think? Practically,
I think it needs to be removed because it causes such a lot of pain in the patient, and plus there are lots of symptoms like she may have bleeding, she may have a lot of tenderness, then fever may be there. So number one, because of the symptoms, I think it should be removed. Number two, there is a chance of the fibroid becoming cancerous. So that is a second.
Yeah. That's very good. Because degenerating fibroid may turn into malignancy.
Especially in postmenopausal women.
Yeah. That is very important. Thank you, Meenakshi. So, question number 3. It's to Asa again, the most intelligent panelist I have seen.
Dr. Rashmi is also here.
Yeah, ma'am. I am going to Rashmi ma'am again. So, Asa, how do you know if a fibroid is degenerating?
Oh, thank you, Dilipda, for putting this question to me. Actually, the fibroid, when the fibroid starts degenerating, they produce symptoms of pain, inflammation, and fever. The pain might be very acute. If the fibroid is having a stalk that gets twisted, and there might be acute pain. Patient will present an acute pain in that stage. And the pain might be chronic also. If the patient sometimes, if it is less severe and lasting for long, then that also signifies the fibroid may be degenerating, especially if the fibroids are too big in size.
Okay. There is another condition, as you have mentioned, that pedunculated fibroids sometimes got twisted and they got degenerated. Okay?
Yes.
So, number 4, again to Dr. Onudhuti Datta. Is it rational to delay the removal of myomas detected near the age? As we have seen in this case, patient was diagnosed to be having a myoma at the time of her 3rd pregnancy, but she was not treated at that time, and she was postponed her treatment up to 53 or 52 years of age. So, how do you think that was the way she was dealt with is a rational? Dr. Onudhuti.
Yeah, Dilipda. Before I start the question, maybe Rashmi ma'am can also help me towards the end. Are you audible? Yeah. Am I audible now? Can you hear me? Yeah. So I was actually trying to see if there are any particular guidelines about these myomas in perimenopausal women, that whether small 3 centimeter, 2 centimeter myomas, whether we should keep them. And because as it is, we know by the time she attains menopause, there's no feeder and they are going to get smaller in size. But then if they have to be definitely treated if the women comes back with any kind of symptoms, like symptoms of pain or symptoms of any kind of spotting or bleeding, but then there is no, I didn't see any particular guideline which said that in perimenopausal, this much of size you have to put the myoma, anything of that sort. But definitely, if I'm leaving the woman with the myoma in situ, which is a small myoma, that was subserosal. This myoma your woman had was the patient was a subserosal myoma. She needed to be annually followed up to see if there is any growth, if there is no complaint and there is no high risk from her side, or if there is any risk, then maybe we should follow her more frequently. Madam, I don't know but if there's anything else you all can add. Dilipda, kuna paisa? I don't know.
Dr. Dilip?
Yeah, can you hear me?
Yes,
Dr.
Dr. Dilip, as he stopped sharing the screen also, as he lost his connection.
Maybe.
Suddenly the screen went off. Probably he's lost his
Yeah.
connection.
Can I share the screen?
Maybe,
Mr.
yeah.
Faraz?
Maybe.
Yeah.
Mr.
Yeah.
Faraz, can I share the screen?
Yeah, you can.
Yes, ma'am. I think, ma'am, he is having some network issues, so that his voice was also breaking. You can proceed.
I think till he comes, you can
Sorry,
take over,
sorry.
Yeah, he is back, ma'am. He is
Ah,
back.
he's back. Yeah.
Sorry, ma'am. Somehow because of
It's okay,
network
doesn't
problem,
matter.
network problem, I was
No,
stuck.
but we should be grateful to God that from Kerala to Guwahati, we can see each other.
Yeah. This is really something amazing.
Yeah, so let's small
Yeah.
pitches are okay.
Did you hear me, Dilipda? Could you hear what I was saying?
You got your questions, then start answering.
Yeah.
No, she finished answering, sir.
I think
Okay.
Go on now.
Okay. So,
case number 4
You go on from
Another
that.
thing.
Ma'am, last question was there to Rasmi ma'am. Number
Okay,
5
okay.
question. Rasmi ma'am, if surgery is planned, what should be the approach? Whether it is a open hysterectomy or laparoscopic hysterectomy. What, in your opinion, what will be best and why? Rasmi ma'am.
In suspected cases of leiomyosarcoma, I think
Here,
open surgery
in this case, there was suspicion actually, ma'am.
Yeah. So that is what I said. So because in laparoscopy, if morcellation is needed to remove the specimen, it is not advisable to do laparoscopy, or we can do morcellation in an endo bag, because in any condition we have to avoid spillage of the contents in the peritoneal cavity. So one can do morcellation within an endo bag and then remove the specimen, because we have to avoid spillage of this content in the endometrial cavity. And if one is not, technical expertise is not there to do so, then an open surgery is always better.
Okay, thank you, ma'am. So,
Shobna ma'am, what is your opinion? Because since you
I'm
are
an
an
endoscopic surgeon. What about you, Rashmi? Are you also an endoscopic surgeon?
No, I am not I do a laparoscopy surgery with a laparoscopic surgeon. I'm more of a vaginal person.
Yeah, so then laparoscopic surgeons would agree with you that laparoscopy is feasible. But then once I had a patient with a 10-centimeter fibroid when she undergone abortion because missed abortion, and the MRI showed spicules on the fibroid, and because of that they thought it is a fibrosarcoma. And then I went and read up, and then they said myomectomy you can't do because fibrosarcoma is a hetho. You can't do myomectomy, that way, laparoscopically. And then unnecessarily I opened her. It was just a twisted fibroid. Can you imagine? It was just a twisted subserous fibroid, and it absolutely useless. No fibrosarcoma, nothing. And that was twisted. So simply I could have taken it out of laparoscope. Unnecessarily I did a open surgery, and it was a waste of time. So a lot of times these MRI reports and all, you can't believe fibrosarcoma. Yes, sometimes it happens, but then it's a dicey situation, because I have unnecessarily done laparoscopy. Anyway, that patient got pregnant. She must have delivered also now. She went back to Dubai. But I'm telling you, these things happen. How can you make out it's fibrosarcoma? Pakka. You can't do that.
Ma'am, somewhere it was written that actually sarcoma is a hysterectomy diagnosis.
Exactly.
Histopathological diagnosis.
Yeah, T2 weighted images on MRI and all they say, but I don't know how much you can do. Even if you do all the 3 markers, LDH, CPK, and everything, all three markers you can do to make out if it is sarcoma or not in a growing fibroid. Even then, in the end of it, you can't give conclusion. It's not conclusive.
Yeah, it's just a hysterectomy diagnosis. Yes,
You
ma'am.
can go to the next case, I think, Dr. Dilip. Case
Okay.
number 5.
5.
I've opened the script.
So patient, this case was given to me by Rashmi ma'am. So she was a 50 years old lady, 75 kg in weight, menopausal for 3 years. She had 2 full-term menorrhagia. She had menorrhagia in 2015. Then endometrial biopsy was done and Mirena was inserted. Detailed biopsy was not available with her. Amenorrhea, she again had amenorrhea in. She came to.
No, sir, I'll read out the case.
Yeah.
So she had menorrhagia in 2015 when an endometrial biopsy was done. And this was a verbal report. At verbal, it was a normal report. So Mirena was inserted to control menorrhagia. And then she was amenorrheic from 2015 to 18. So the Mirena was removed in 2019. And she became amenorrheic in 2018. So after 1 year, 2019, the Mirena was removed. But subsequently, she developed the genitos symptoms. So Primarin vaginal gel was given to her for vaginal dryness, for which she used it for 6 months and then she discontinued on her own. She was hypertensive since 2018 on medication and well controlled. Then after the Primarin gel, she continued to have symptoms of genitourinary symptoms like severe vulval itching, periuria, dysuria, and hot flashes. She had spotting once a year, okay, and for a few days for coffee ground color, but for which she had not approached for any treatment. And the last episode of spotting was 1 year back. The next slide. She first came to me in 2021. On examination, she had left breast galactoria, and on speculum examination, the cervix was normal looking and healthy, and for which I took a liquid-based cytology, and it was reported as normal. And on PV, the uterus was 12-week size with irregular surface, and she had varicose veins present up to the thighs. Next slide. Yeah, so like I said, the pap smear was negative for malignancy in ectopia. She had galactoria, for which a mammography was done, which showed fibroadenosis by rates 2. And since she had complaints of joint pains off and on, her RA, all this was done at some other place. RA factor was done. RA negative, she was diagnosed arthritis on therapy with an orthopedic and a physiotherapist. And in USG 2020, that is when she had multiple fibroids of 1 to 3 centimeters size, and she had mild fatty infiltration of the liver and pancreas, and also an hemangioma in the right lobe of the liver. She was no history of hemodm, and a CA 125 was normal, as with other lab parameters. So that next slide. So when she came to me, she had the symptoms of genitourinary symptoms, and VMS, the hot flashes were not very severe. So given the history of hypertension, obesity, presence of fibroids, I chose to give her Istiol vaginal cream, and she was very much for that. I want to take isoflavones. So I said, okay, you can take, but she was advised to come for regular follow-up. And supplements like calcium, vitamin B12, D3, and multivitamins were also given. She was also going to the orthopedic and, of course, the physician. But on sonography, endometrium was 7 mm, which was borderline because she's an hypertensive. So the cutoff is, up to 4 mm is a cutoff for a normal patient. But on an hypertensive, you can a cutoff of 6 to 7 mm is also acceptable. Even up to 8 is also acceptable. But still, I got an office I advised her an office biopsy. But the patient refused to do that. Then she came to me again in June 2021 with mild relief of the GSM, because with the Istiol vaginal cream, she had UTI, culture specific antibiotics was given, and then she was advised to come back again for follow-up. Then she came to me in September 2021, 3 months after that, when she had severe VMS symptoms with insomnia and bloating. And then with careful counseling, because the estriol vaginal cream was not working, she was not very much for the transdermal one. So I gave her continuous sequential MHT. But 1 month after that, she came back with complaints of mastalgia and bloating. Like you remember, she had fibroadenosis in the mammography. And when she was on this continuous sequential MHT, so she wanted change of therapy. But her VMS is much better, but she was having the progesterogenic side effects. But then again, the USG had repeated the fibroids were the same, but the endometrial thickness was still 7 mm, which was there previously. So next slide. It's a bit long case, but she has been coming to me for regular follow-up. So then I said that it's better that you undergo hysterectomy because you have fibroids and all other things are there. But since she did not have any social support, she refused for hysterectomy also. So, and then she stopped the MHT on her own, again started the estriol vaginal cream. But after that, because of maybe the endometrium and the fibroids, because the fibroids are growing in size, she came back with menorrhagia. But just to control her menorrhagia, we went in for an endometrial biopsy and the LNG IUD, because I said at least a menorrhagia bleeding will be controlled with this. But the HP showed disordered proliferative endometrium. Then I inserted LNG IUD. She went back to Canada, but again a few 2-3 months after that, she again had menorrhagia, and the USG showed the same fibroids were there, but the endometrium was linear, 4 mm. I had done her biopsies, if you would remember. She again came back to India, and then finally we did her vaginal hysterectomy, and it was a huge uterus, and she was almost 50 to 53, and she wanted her ovaries to be preserved, and since she did not have any history of malignancies, no family history of malignancy also, and her own, none of her reports were suggested, both the ovaries were preserved for her.
So, can I ask the question?
Sure.
Okay.
Sorry, sir, I took over the case, but I thought.
It's okay, ma'am. It's okay. So you have it is your case, so history will be better from you again.
Sorry,
so,
sir.
So first question. No, it's okay. I am very much grateful to you. After it's a long case, so patients leads to the management of the cases. So
Your voice is
breaking,
Dr. Sharma.
Dr. Dilip, your voice is coming a little.
Can you read out the questions, Dr. Manjima?
Okay, I'll. What are the situations, Dr. Rashmi, when you would prefer to start MHT?
Okay.
Dr.
So
Rashmi, since it's your case, I'm putting the question to you.
No, we can have a discussion on this also, because this is the most practical question which is there.
That is why
so like personally, I mean, according to the guidelines also, I would prefer to start MHT only in a patient who is symptomatic. If a patient is asymptomatic, I would never put her on MHT.
And even I would like to add, madam, that
other panelists.
Can I add something?
Yeah,
madam, I would also,
please add.
Yeah, I would like to add that we would start between the age group of 40 to 55. It's no point starting it. We should always start it in women who are less than 60 years old. Even in the menopausal transition stage, if she has symptoms which are moderate to severe, I don't know if I would like to start with mild ones, but moderate to severe cases of vasomotor symptoms in GSM, we would like to start. And especially in that in the transition period between 45 to 55 years with such complaints.
In what situations strictly would you prefer the use of topical MHT over the systemic preparations?
Madam, in cases of genitourinary symptoms of menopause, the topical MHTs work very good. Especially patients who come with all genitourinary symptoms of urinary urgency or overactive bladders and these kind of things. It is always better to use topical MHT in such cases.
Dr. Meenakshi, what are the precautions you would follow before prescribing MHT? Dr. Meenakshi, please. Dr. Meenakshi, can you hear me? Hello, Dr. Meenakshi, or maybe
sorry, I
somebody
was
else.
muted.
Somebody else could take up this question. What about Dr. Mamta? Mamta?
No.
Yeah.
Meenakshi is there. She just forgot to unmute herself. Again, unmute yourself.
Okay. Meenakshi, please then, please.
Yeah.
Answer this
I've
question. What are
unmuted
the
myself.
precautions you should follow before prescribing MHT?
Yeah.
Dr.
Before
Meenakshi.
giving MHT, I think we should do a pap smear, do a mammography, liver function tests, and a thyroid, blood sugar, all the basic investigations, and bone mineral density, I think, if possible.
So
Am I audible?
this, you're audible. Yeah, you're audible. Dr. Mamata perhaps could take the next question. So
Manjima
this
Baido,
patient
Manjima
has-
Baido,
Okay,
Manjima
Dr.
Baido,
Asha.
I just want to add here one point. Precautions,
please
one should start before. We should select a patient. We should select the woman who seeks for the MHT. It should be the right patient, right dose in right time. We should start this treatment. This is the ideal thing in the very low dose. It should be very low dose.
Right. Thank you, Dr. Asha. Dr. Mamata, since this patient had a VT right up to the thighs, so what special point we should have kept in mind when the MHT was being prescribed?
Before prescribing MST, every patient's treatment should be individualized. And
No, this patient I'm particularly stressing on the VT. He's got VT.
So we can
Up
go
to the
for a
thighs.
transdermal patches, transdermal estradiol, because it will be safer for her if it is if the symptoms are severe. Otherwise, and also in the history part, we can ask her for if there is any history of angina, any history of thromboembolism in her family, in their first relative. That could also lead. That could also a risk factor for her.
So we have come to the end of the slides. Dr. Dilip, can you again come back? All right, Dr.
Manjima
Asha,
Baido.
yes.
Here
Dr.
we can
Asha.
add. Here we can add one more thing.
Yes.
Special point to keep for MHT with transdermal are definitely good, but still they have a risk factor for the patients who are suffering from thromboembolism. So we can always go for alternative therapies in this patient if she, at all she
That is
requires
very good.
this therapy.
Alternative therapy such as, Dr. Asha, such as, Dr. Please elaborate.
Alternative therapy would work for patients with hot flushes.
Can you stop sharing if you have finished the slides?
Okay, I can now
can go
stop
into
sharing.
gallery
We have
view.
finished the slides, yeah. Okay.
So for GSM, alternative therapy is usually not very effective. Alternative therapy like isoflavones are more effective in BMS than for hot flashes and for the genital urinary symptoms. Like even isoflavone gels don't give such good results.
Yes, ma'am.
What about
Madam,
tibolol, ma'am?
what about
Tibolol?
vaginal DHA, ma'am? Vaginal DHAs can be added, and those kind of
Vaginal
things,
DH is not available in India. It's still
ma'am,
not
they're
available.
just coming up now.
Yeah.
There is a cream available, madam, now.
Now there's a cream coming up, ma'am. DHA cream. I forgot the name.
It is news for us.
Yeah, DHA cream, I also don't know. Nobody has not, I mean, come to meet us still.
But
they are planning to launch that.
But I think where there are so many veins on the legs, MHT has to be avoided in this patient because it will be increasing the vein size, or it could be even going to
risk
cause
would be too much.
stroke. And I don't think any of the MHTs can be given, and maybe we should go in for venlafaxine or gabapentin or something like that.
You're right.
Because
Gabapentin
isoflavones
would be
also
good.
we do not know. Tibolone also we do not know. Transdermal also with so much of veins on the legs we do not know. About the fibroids, there are studies which say that fibroids, even if they grow, they are not symptomatic. but then you have to learn from your own experience, because there are so few fibroids where we give MHT that we can't give a study as such.
Like, but like,
Not
ma'am,
easy.
she was a very obese lady also. BMI was more than 30. So that itself, her own endogenous estrogen must also be high.
Exactly.
So that also would lead
Yeah.
to, but if she has severe GSM symptoms, would the endogenous estrogen be so high enough to cause the growth of the fibroid?
That's we don't
So
know. That is
what
So it was very
you have to
contradicting,
say?
Actually, this patient was my friend also. And
so
I
it's
took
not,
a,
everything is not given in books, and it doesn't happen as
And
per
here,
book.
I
so
think we
with
have to
very
add
good
this
counseling,
lifestyle
very good
management.
counseling. I had given her everything, and she was explained everything. We even actually I did her ECG. I also did her cardiac
No, after you
echo.
did the hysterectomy, could you start giving her estrogen, and was she? But again, the veins are there on the legs. So
The
what do you
veins
do
were
now?
because she also had fibroadenosis. She had very bad case, so she had a lot of issues, and it was very
breast pain is
cardiac.
another contraindication for, means relatively, contraindication for estrogen therapy, because the pain may increase.
Yeah.
So now
Yeah,
your
the
patient,
pain
I
will.
think you will have to be giving her venlafaxine or gabapentin or something, no?
Yeah.
And always in menopausal management, the first thing that comes to mind is the lifestyle changes, reduction of weight, exercises, meditation, yoga. All these are like part and parcel of our lives. And then we come to the medications and the treatment and the surgery and all. So lifestyle.
Practically,
very,
a lot
very
of people find it difficult to reduce the weight, because it has taken many years to put on the weight, and it will take many years to put off the weight.
To lose the weight.
So
And
overnight,
it is going to increase in the near future. In UK also, they said by the time it is 2025, you will have a lot of obese women, a lot of endometrial, hyperplasia and
already
cancer.
in America, they can't put a trocar inside, because at trocar ka length tak utna fat hota hai. It's
I
very
think you have to
difficult.
make, something like compulsory from the government side, like you do some farming or something. Everybody has to go to the field and all something drastic like that.
Madam, there is
Because
this local
obesity
hospital
will
where my
keep-
friend owns. Shobna ma'am, there is
Yes,
a local
yes.
hospital in Bongargaon where my friend's the owner. They give an incentive of a foreign trip to all the doctors until they keep their weights constant. If there's an increase in weight, the
Oh
foreign
my
trips
God.
are cancelled.
If there is an increase in weight, what happens?
The foreign trip gets still. Otherwise, there is a hospital-sponsored foreign trip
So
every year
many
for the
doctors
doctor.
are now
Oh,
religiously
foreign
attending
trip.
the games.
Acha, ye
Yeah,
COVID aa gaya
so
tha,
that
nobody
Right,
wants to
Jyoti?
go abroad also.
that
Jyoti,
incentive,
so many
incentive is
are
gone.
seen attending gyms now, right?
Yeah,
That's
foreign trip
interesting.
if you reduce
No,
weight.
madam, not
Wow.
me. It's in Bongaigaon. It's not here.
Where?
They live in
Bangaigaon?
Bongaigaon.
Where is that?
Bongaigaon is about, ma'am, 6-7 hours from Guwahati. It's about 6 hours drive from
That
Guwahati.
means the
They get
Northeast is ahead of the rest of the country, I think. Imagine
Yeah,
giving
yeah.
foreign trip
Women
to
are
people
always
for
ahead in
reduction of
it.
weight. My God.
Yeah.
The more east
No,
you
but
go, the greater woman power it is.
yes, yes.
Yeah,
In the
yeah, I
matrilineal
know that. I've
society,
been to Northeast, and I find that the government jobs are offered to the women in Meghalaya.
yes,
I-
yes, yes,
same
yes.
in
Meghalaya is a
Guwahati.
matrilineal society. The woman rules the home and the heart, everything.
In Guwahati
Madam, they
also.
come out
In Meghalaya.
para 8.
Yeah.
Ma'am, in Meghalaya, they are para 8, para 9. You should see their abdominal tones. They are like
Yeah.
firm
This
because
is
they
because
work
of the
very
walking
good.
in the hills that builds up the strength of your
They walk
muscles.
in the
Okay, now
hills.
we are going away
Yeah.
from the subject. If we when I have finished, then we'll stop
Ma'am.
the recording and then we will talk.
Rashmi ma'am, I just want to
Yeah.
ask you, in your case, you have put LNG IOS in the same setting when you are taking the endometrial sampling?
No. I took it. Later on, I took it. I did the endometrium because she had menorrhagia with a 7 mm endometrium, and she was not willing for hysterectomy at that time because of social reasons. I took an endometrial biopsy, waited for the report to come, and then I inserted LNG IUD for control of menorrhagia. And then subsequently,
Very important, because when you put it along with endometrial biopsy or along with hysteroscopy, that thing just jumps out. Initial years, I used to do that. I do a hysteroscopy, remove the polyp and put an LNG IUD at the same time by the time the report comes. But then they just throw it out, because then there is little bit also when you enlarge that uterus, no? As the LNG IUD will stop.
discharge.
And even in very heavy flow patients, when you put LNG IUD, it flows out. So only after the bleeding has stopped, after there is no interference, then only the LNG-IUD will stay in space. That is there. You can't put it and do it at the same sitting because the patient doesn't want to come again and again to the doctor. They want to save time. They are so busy. They never want to come. They would be happy if you go and put it in their house also. That is also, they'll be very happy. Or in their office, when they're sitting, you go and put it, they'll be happy. Yeah, ye jamana aa gaya abhi. They don't want to come to you again and again. But in LNG-IUD, you can't.
Take.
Secondly, sometimes you get a report of a malignancy or an ATP and you have to again, remove the IUD.
Exactly. So however they force you to do it at the same sitting, or however you want to please them, please don't do it at the same sitting. This is what I want to say. I don't know
Thank you,
what
madam.
people think.
Yes, yes, that should not be done ideally, actually. Manoj, you want to say something? Manoj from Raipur is very actively sitting there.
Yeah, ma'am. Excellent program today, really. Congratulations to everyone. And looking forward to urogynecology webinar on September 3rd September. First Tuesday.
Okay.
আপনাক কোৱা হৈছিলে ন যেনেকে বুজোৱা গৈছে এনেকে খাবলৈ
Okay.
That
Yeah.
was Asami.
No, I can't understand any of Assami or Bengali. Anyway, so if if we do not have anything on the subject anymore, what about the panelists?
Ma'am.
Yes, Dr. Yashodhara, please put on your mic and give us some pearls of wisdom from Lucknow. She's the most senior gynecologist from IMS. Much before I joined IMS, she was already in IMS in prominence. So, Madam Yashodhara, we would like to hear from you. Can you please unmute yourself and give your viewpoints?
Thank you, Shobna, for the invitation. And thank you because Lucknow Lucknow Menopause Society is number 4 to come up in 1998. So it's a very old society.
And Yashodhara Madam has been active in it right from the beginning.
Yes, I'm a founder member of the Lucknow Menopause Society.
So
Anyhow,
tell us.
yeah, it's a very good, your talk was excellent, Shobna, because you have not given this, you have given the solutions and why the thermal ablation should not be done. That was a very important part which you have covered.
Only for hyperplasia, not for all patients. Only for hyperplasia.
I said that.
Yes.
For the hyperplasia, for endometrial hyperplasia, the thermal ablation causes the synechia, and synechia produces so many other problems. And because of that, the follow-up is a very difficult thing. I suppose the thermal ablation is almost dying. No, what is your opinion?
Even I'm not doing much of it now.
But
ever since LNG-IUD came, thermal ablations, because LNG-IUD was costing the same 30 years back as it is now. And at that point of time, it is almost equal to hysterectomy. And now it is like way behind hysterectomy. So they are accepting it. So it's much easier now.
Much easier. So it came, but it did not stay for long, the thermal ablation.
Yeah.
And the panel was also very good. And
Thank you,
the Guwahati Society has really put a hard
very lot of inputs and very hard work and very energetic.
Very hard work. Dr. Marijima, you are doctor?
Thank you. I'm Dr. Manjima Ganguly. I'm Vice President Cox.
Manjima Ganguly and Dr. Dilip. And all the panelists, I was just listening, it was a wonderful.
Dr. Sharma is the president.
I just want to add this, leiomyosarcoma on MRI is producing such nuisance.
Exactly. Her husband is a radiologist. She should know.
I do not know why.
You don't have family fights at home.
I'm not in favor of doing. Shobna, I'm not in favor of going for MRI for each and every fibroid. Uterus, because you can get in the ultrasonography, the 3D and the 4D, you can get each and every this thing. Or if you get any problem in the submucous fibroid, you can always have a hysteroscopy, which is very good. You can have the excision at the same time. The polyp also can be excised at the same time. If you do not have a hysteroscope, you can always refer to a person who has got a hysteroscope, and patient will come back to you for the follow-up and other things. So I believe that it should be done like that, because I have also had 2-3 cases and with the very influential people whose wives have been diagnosed fibroid is having a sarcomatous changes. So
I
they
think
got
you must be the only gynecologist who has seen 3 sarcomas. I think every gynecologist with great difficulty will see 1 sarcoma. It's
No,
so
I
rare.
have seen, it's, Abhi, these days, one of my relatives, she's in US, her reports are pending. She also had the sarcomatous changes in the polyp. She had gone to this thing, total hysterectomy, bilateral syncytioparectomy with, they do multiple punch biopsies for each organ at the one time to rule out everything. They have done the liver biopsy and the omental biopsy, every biopsy, they have done whatever they could do to rule out that it has not been metastasized. This histopathology is pending because it has been done only last week. So this week, probably in a day or two, reports must be available. But because once you say in the histopathology, if you see sarcoma, yes, it is all right. But MRI cannot give you sarcoma is a histopathological diagnosis. It's not a radiation diagnosis.
That's
It's
what
not
Asha said.
diagnostic
No, it's a
diagnosis.
hysterectomy diagnosis, she said, not
Yes.
a histopathology.
Yes. So if the MRI people write it, it puts to gynecologist and the patient. Gynecologist still happy because they will do the hysterectomy, but the patient is so much anxious. You can imagine one person who was a consumer forum lawyer, and his wife had this. He came to me through some person. He said, "Madam," I said, "go to AIMS and then get yourself diagnosed." AIMS is really very difficult to see the people because it's so much of rush and all these things. And to see senior person is really difficult. So they have come out that she did not consult it there. Then again she went there. Then I referred to one of the laparoscopic surgeon. He said that I will do a frozen section, ma'am, for that fibroid to find out whether there is a sarcoma or not. If it is a sarcoma, I will do accordingly, otherwise not. And in the frozen section, there's no sarcoma in the fibroid. And he came back to me, he said, "Madam, I want to do 3 crores litigation to that gynecologist who has referred me to MRI, and MRI has said to sarcoma." I said, "I will not advise you, but you can do whatever you like. I do not know further what he has done or he has not done, because he was going to abroad. It was just a medical checkup in which the fibroid came and for which she has been referred to MRI, and the MRI has given the report of the sarcoma. So this is really not needed. It produces so much hyperactivity is not really needed, I feel so.
Yeah, MRI is still giving wrong diagnosis. Giving the litigation against doctors is nonsense, because even courts are giving, lower court gives one opinion, higher court gives another opinion.
That is nice,
The way they talk like this, it's nonsense. Anyway, that's
So
another
it is basically the diagnosis of the myosarcoma should not be, suspicion can be there, but it should not be laid down on the MRI or something, because it is a histopathological diagnosis. It is
very
not
good take home messages that we are getting.
Yes,
from
yes,
this
ma'am. In my
good panel and very good cases from Guwahati.
And I say that MRI in the fibroid.
In my case also, his diagnosis was histopathological diagnosis. This was not an radiological diagnosis. It was a post-hysterectomy biopsy, and it was a histopathological diagnosis, not an radiological diagnosis.
Dr. Dilip, MRI is not needed in each and every case of the fibroid. It is only should be limited to a very few where you really need something to save the uterus.
In postmenopausal lady, MRI is not necessary. In the lady, only in reproductive age group patient, when we want to preserve the uterus, then only MRI has something to do. That's
even
what
there,
we
I have
are
a
following.
patient who is undergoing myomectomy.
If you are in a doubt, that you will not be able to remove, only then.
Because when you're doing a laparoscopy, you may miss the fibroids which are deep inside. Their MRI may help you to count. If you're doing a laparotomy myomectomy for multiple fibroids, again, your hands are better than the MRI. But for laparoscopy, maybe MRI, because you will miss out the intramural ones otherwise.
The 3D ultrasound gives you such good image and the depth and everything, I believe, on the 3D ultrasound.
Okay, that's a good take. Fine.
Thank you
Okay,
so much.
okay, thank you.
So much.
Thank
It
you,
was
thank
lovely
you.
discussion, lovely discussion. I was just going to leave and I was writing to leave. So because I had got something to do.
That's why I
So
called
now
you
I'm
back.
leaving.
Value your
I'm
input,
leaving.
Dr.
Thank you
Thank
so
you,
much.
Yashodhara
Please
ma'am,
permit me to leave
for your
this
feedback. It was really nice.
very nice discussion. Thank you so much. Thank you so much.
Thank you, ma'am.
Okay, then I think we are nearing the end, and we really thank you, Guwahati, and all people from all over India who have come. Jyoti has come from Raipur. Manoj has come from Raipur. Jyoti is the joint secretary. Jyoti, you want to say something?
Hello, ma'am.
Yeah, she's my joint secretary. So, bolo, Jyoti.
Hello, Dr. Jyoti.
Raipur is closer to Guwahati than Kerala.
I always say that, Shobna ma'am, your all the panels remain very, very practical, and the things which are not usually discussed in the panels, the small things and the small practical tips you always bring.
No, Jyoti, I don't know. I don't take any credit for this. I only told Dr. Sharma, please give cases from Guwahati, and it is all credit to the Guwahati people. I have done nothing in the panel. Let's be honest about it. I have not done anything in this panel.
This was your guidance, Sobna. Sobna ma'am, this was your guidance. This was your guidance.
May I
said
request
ma'am.
the people to just fill the forms for the Hot Flashes Pan India study, which Shubhra madam is doing.
Guwahati, please give me a few Pan India hot flashes study from your cases. It's for a national cause, and we need Eastern data also. We are only having Central India, Northern and Southern data. For God's sake, give us a few data from the Northeast so that it is a truly Pan India study.
Yeah.
And IMS can give 5,000 rupees for 100 forms, 10,000 rupees for 200 forms. So anybody in medical college, if you can give any of your students this, they can go to a 5-star hotel and eat food after filling up 200 forms. And they have to put it in an Excel sheet and give it to me. The forms are available with Paresh. They can fill it up. If you want, we will courier the forms to you. Paresh can courier the forms to you, and the children can do this work. I know that seniors can't do it. Itna busy rehte the, how can you fill 100 forms? So whatever forms you can fill, but we have got money in IMS to give the children. So anybody in medical college, if you can give data from Guwahati for Pan India study or hot flashes, we would be very happy. Anybody in medical college?
Shobna ma'am, great initiative, ma'am. Great way of motivation.
Any medical college person from Guwahati here?
Yes. 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 We will do
Yeah,
it. We'll
please,
do it.
we will give you money also for those people for an incentive. I know 5,000 is nothing, 10,000 is nothing, but they can just go and eat in a 5-star hotel. No, that's it.
It's a good incentive, ma'am.
They want to use it, they can use it. It's up to them. And even if Shobna madam, I can also can have one help if only pictures they are giving.
Yeah, they
only
can give
pictures or a hard.
Yeah, instead of sending it by courier, you can even, but to photograph so many pictures, it's so difficult, no? So most people are doing courier.
Yeah, so that
if it's just
will
5,
be a
6
better
cases, you can just take a photo chat, WhatsApp photo and send it.
Send. And if
okay. So with that, we will, I think we will call it a day and hand over to Guwahati for Thanksgiving and things like that. Okay.
Thank you, Guwahati team. Such a wonderful webinar today. Thank you so much.
Thank you so much.
Thank you. On behalf of Guwahati Menopause Society, I request Dr. Meenakshi say the vote of thanks.
Thank you, Dada. Guwahati Menopause Society was proud to host this webinar after a long time, and thank you, Shobna ma'am, because without your push, we could have done nothing. The day you rang me up and told me ki tumko karna hai ki nahi karna, that was the time that I decided maybe we should, give it a last try, because you have been trying to get us into gear for such a long time. Thank you, ma'am, so much. Thank you. And thanks to all our panelists. Thanks to all our, including Rashmi ma'am. She had come from Vadodara. And thanks to invite. Thank you, Rashmisha ma'am, Anju Soni ma'am, who's left. Thank you, everybody. Thank you so much. Thank you.
Thank you. Okay, then. So good night, guys.
Good night.
Lovely
Bye, good
meeting all the
night.
lovely people from Guwahati and Faraz from ClearNet for organizing this whole ClearNet team. We thank you for coming week after week and being with us in this academic
Was very
endeavor.
glad
Thank
to
you so
have
much.
you all people
Good
back.
attendance today, ma'am. Very good attendance.
Yeah, so Guwahati rocks.
Thank you, ma'am. Thank you.
Yeah,
Thank you, Sona ma'am.
Okay, bye.
Ma'am, we'll have a
you.
physical conference in Guwahati. We'll all will go there.
Okay,
I've
okay,
gone
that's
there
very good.
twice.
That's very
I've
good.
gone to
Very good.
Meenakshi house.
Kamakya
Definitely,
temple is
please
very
come.
beautiful.
I've gone to
Please
Kamakya
come.
temple. But
Let's
I
take
was
you
so
there to
shocked that
Kamakya
day.
temple.
There was one goat's head like sitting in front of the god. I was really shocked. One chota sa head tha udhar.
If you
I said, my
come
God.
during Durga Puja, you'll see even more.
And
of
when
such
there is a
things.
big queue there and you have to have special darshan, 500 rupiya deke. But 500 jo bahut kam hote hai lagta hai mere ko. Na zyada nahi
Yeah,
lete
they
wo.
don't take much. They don't take much.
Yeah, it's not very costly. Guruvayur temple here, they take 1,200. Tirupati temple, they take 10,000. Kamakya temple.
We will ask Dr. Manjima to get the special pass for all of us.
Yeah.
Thank you. Thank you. Okay, I'll try.
So you
Anyway,
have this.
that was a good experience.
You have this sacrifice of the goat during Durga Puja at Kamakya.
Not only goat, we have the buffalo also, and it is mainly the buffalo which is sacrificed, especially during Navami. The
Also
goddess
pigeons.
Kamakya is actually she sacrifices given to her.
Yeah, I know,
this
because in
form of
my,
Shakti.
in my village during Kali Puja we have this Patha Boli. What do you call it in Assam?
Assam also
Kali
we
Puja.
have Patha
Yeah,
Boli.
Kali.
We call it that
during
also.
Kali,
We
during
have
Kali
buffalo
Puja we have
also
this.
sacrifice.
We have
During
more
Kali Puja in my native
But I am
village.
a vegetarian, Manjima, and to find a goat's head sitting there, I was little,
But
thoda ye
our
ho gaya.
goddess is not vegetarian. Kamakya goddess
Yeah,
is not
that's, we have to
vegetarian.
respect
It is an
the,
aggressive form of Shakti.
whatever it is, we have to respect the forms of worship that everybody has got.
So
In
there is,
Thailand and all,
there
if
are,
you go, you will see beer bottles in front of the
yeah, that
Buddha's.
was what I was getting. There are beer bottles also given, whiskey bottles are given as offering to the.
It's all everybody's way of
Yeah,
thinking.
I've heard that. So that happens where, ma'am?
Thailand
Which
actually,
place?
Here
Thailand,
also,
Thailand.
at Kamakya Mandir, there is Babula Mandir. No, here also it's offered. Everything.
So whatever
Non-veg, meat, all
attracts
types
people
and
to
all
God,
rice.
that is good enough. You have to accept that everybody is eating non-veg, so what is wrong in keeping that as an offering? That is the one thing.
Yeah.
You cannot say no to that because many religions, this cutting of animals is a fact as a part of religious exercise. So it's okay. But I'm just telling you, I just told you about that because to show you, I did go to Kamakya temple. Proof dene ke liye bola.
You can go to Vishnu temple where we have vegetarian things.
Wait. Yeah, I will go to Kamakya temple also, goat or no goat. That doesn't matter. That's not a point. And there is water flowing on your leg, no? Some unseen water coming from somewhere and all that.
It is very ancient. This part of Northeast India, it is even very, very ancient, much more ancient than the rest of India also.
Yeah,
So it
yeah.
has a very good history.
Yeah, there's a lot of
Time
very
of Lord
positive
Krishna.
vibes are there inside that place. Very nice.
Kamrup is a very ancient, place.
Very nice, very nice. I had a good feel good factor when I walked through there.
Mention of it is in Mahabharata, Ramayana, everywhere.
Yeah. Oh, okay, good.
Krishna had come here, no? For
I don't
his
know, Baba. I
marriage
don't know.
of Aniruddha to Usha.
Acha. Okay, good. Okay then. Chalo,
Chalo, ma'am.
lovely
Good
meeting all
night.
of you.
Okay, good night.
Bye.
everyone.
Thank you so much.
Take care. Thank you, ma'am. Thank you.